Signing off because I washed my hair.
Okay, so I've just made a request to record the session. So you should get a message on your screen that allows us to do that and to give us permission to record. So if you don't mind clicking
click on got it.
Got it, and that's your permission to be recorded. So thank you very much for that. I'd like to welcome you to this afternoon's late lunch session with Janine and Caroline. We are very excited to have not one, but two amazing paediatric continence nurses with us today. Janine will be presenting majority of the information today. She is a maternal and child nurse with over 20 years experience in working in paediatrics and over 14 years as a continence nurse specialist, and she works with the Continence Foundation on our helpline. And Caroline has been a nurse for longer than she cares to remember and has been probably, she thinks, 26 years working in paediatric continence and her whole career in paediatrics. So we are extremely thrilled to have not one, but two amazing people who together make up an awful number of years of experience. So how fantastic for us. So thank you both very much. And I'll hand over to Janine now, who's going to share with us some information on supporting bedwetting in kids.
Okay, thanks, Amy, for having us today. So today, I guess the aim of the session is to increase your knowledge and understanding about bedwetting. And I'll actually refer to it as bedwetting. You may also know it as enuresis or nocturnal enuresis. But today, for this presentation, we're just referring to it as bedwetting. And by the end of the session, I hope you'll feel more confident and you'll know how you can help your child and where you can actually seek help. So okay, so how common is bedwetting? Well, we actually don't give it the name of bedwetting until the age of 5. Prior to that, we classed as normal child development. So after 5, if your child's still wetting the bed, that's when they're classed as a bedwetter. Now, we know bedwetting can affect up to 20% of 5-year-olds. So if you think in a class of prep, you've probably got about 4 to 5 children who still wet the bed. For 10-year-olds, it's about 10% and 3% of 15-year-olds still wet the bed. We also know that there's about 0.5 to 1% of adults who wet the bed. So there's certainly some myths around bedwetting, and some of these you'll hear people say that the child's just lazy or attention seeking, or they're just naughty, or they just don't care. They don't seem to worry about it. Basically, I've never seen any child who wants to wet the bed. One thing we do know that there is a medical reason for it. So what are the main reasons? There's 3 main reasons why children wet the bed. The first being the lack of sleep arousal. So they actually just don't wake up to that sensation of a full bladder. Now, a lot of parents refer to their child as being heavy sleepers, but in reality, often they're actually poor sleepers with a low sleep arousal. And we know children who suffer sleep apnea are more common bedwetters, and also those who have problems with their tonsils and adenoids. Second reason is the lack of the antidiuretic hormone. So overnight, there's a hormone released by the brain called vasopressin, and its job is to slow down the production of urine overnight. Now, if that's not released in sufficient amounts, these children make lots of wee. And then if that's combined with the lack of sleep arousal, basically they don't wake up to the sensation of a full bladder and the wee has to go somewhere, so they wet the bed. Now, the third reason is an overactive bladder. These children normally wet more than once through the night, and they may have some urinary urgency through the day also. Now, your child could have all 3 of those or just one of those, but basically we do treat it the same initially. We know there is a strong familial history with bedwetting. If one parent was a bedwetter, you've got about a 35% chance of having a bedwetter. If both parents were bedwetters, you've got up to about a 75% chance of having a child who wets the bed. But saying that, if you grew out of the bedwetting when you were 8 or 10, that doesn't mean that that's when your child's going to grow out of it. In reality, we have no idea who's going to so-called grow out of it and who will go into adulthood as a bedwetter. Now, there's 2 different types of bedwetting. Primary bedwetting are those children who have never been dry. And then secondary bedwetting. These children have normally been dry for about 6 months, and then they regress again and they start wetting the bed. One thing we also know is that it is more common in children with ADHD to keep relapsing with bedwetting. If your child has any daytime issue, we also treat the daytime issue prior to treating the nighttime. So what's the first line management? Well, one really important thing is that your child is a good drinker throughout the day. Now, often parents say, I have no idea, whether my child's drinking at school. One thing I would suggest is maybe send them with a drink bottle and mark that drink bottle how much to have by morning tea, afternoon tea time, lunchtime, that they've got marks in them so they know how much to actually drink.
Janine, just to make a comment on that.
Yeah, please.
Often with children, younger children too, it's a bit, sending one big drink bottle is often a bit daunting. So sending 2 smaller drink bottles, one to have at morning tea and one to have at lunch, and that's a lot more achievable often.
Yeah, exactly. That's the other one. Yeah, certainly agree, and that's another way of that I often suggest as well. I think that's a really good suggestion. And we know that particularly boys, and Caroline, you can probably say this too, is that they're usually really busy at school and they just don't have time to drink, and they might just take 1 or 2 slurps from their bubbler, and then they do all their drinking between 4 and 7 o'clock at night, which means they're going to be more likely to wet during the night. Whereas if we can have them drinking well throughout the day, and have a good drink of water when they get home from school, and at dinner time a glass of water, they're less likely to need a lot of fluid late into the evening. So we're not restricting their fluids, we're just trying to bring them forward.
And even I've found implementing a reward program if children are not very good drinkers at school, encouraging them not to drink out of the bubbler, because you really don't have much. You might think that you're having a lot, but you really don't have a lot. So maybe rewarding them, for having their drink at morning tea and rewarding them for having their drink at lunch.
I think that's a really good thing, because sometimes parents say, oh, look, I've got a sticker chart or reward system if they're dry overnight. Well, your child can't actually control that overnight wetting the same as they can their fluid intake, which is going to help them to get dry overnight. And having a good bowel routine, sitting on the toilet at certain times and things for their bowels. If they've got constipation, you can reward them for things that they can actually achieve, whereas the bedwetting is a bit trickier for them. Treat constipation, and this is really important, and I will explain constipation in a bit more depth later on in the presentation, but constipation we certainly have to treat. Make sure your child's emptying their bladder just before turning off the light at night. So if they're readers or something, make sure they start off with an empty bladder as they're going off to sleep. You can take if they're wearing a pull-up at all, you can take it off for 1 or 2 weeks and just see what happens. Just make sure you've got adequate bedding protection, a bed pad on the bed so your child's not waking up in a cold, wet sheet. So I guess the next thing is, what will a health professional do if you go and see someone? I guess they'll take an accurate history, because we really need to know what you've been doing to know where to head to. The other thing would be a bladder and bowel diary. Now, often parents find these really painful to do, but as clinicians, I'm sure Caroline will agree with me, they give us really good information. And then we start to understand what's going on with your child and the best way to actually encourage them to have dry nights.
Yes, Janine, yeah, bladder and bowel diary are excellent tools for us to estimate, you know, how the bladder's functioning, whether the children are constipated, and we know that constipation has a direct effect on the bladder. So both are really very important.
Very important. An abdominal palpation. So have a feel of your child's tummy, just to make sure we can't feel any constipation as well. Test the urine, make sure there's no signs of any infection. Check their back and spine, just to make sure everything's normal. Then they might suggest an alarm program for your child. And if an alarm program doesn't work, there's medication that may be considered as well. So let's just have a quick look at what a bladder and bowel diary is like. So a bladder diary, this is just one off from the Continence Foundation off our website. But basically you could just have a piece of paper, draw 5 columns, the date and time, the amount of fluid in, the type of fluid in, how much your child's weed out, and then any comments at all, whether there's any urgency, whether the wet was really bigger than normal, whether they had any problems through the day. And then we like a 7-day bowel diary. And then what that does is help to give us an idea whether your child does have any underlying constipation. Now, I know these can be challenging to fill out, but as Caroline said, they give us really good information, and we then know the best way to actually help your child to get dry.
I'll just make a comment. Oh,
yeah, please.
So just with the bowel, including a bladder diary, it's good if you can not do it on a day that the child is at school. So a day that they're at home, like the weekend or the school holidays, where you can just devote the day to doing it. And it's better off to get, you know, a really good 24-hour bladder diary rather than getting small amounts each day, and that will give us the information that we need.
Yeah, and that's where, you know, yeah, if you can only get 1 or 2 days, that
yes,
complete is much better than just a ad hoc diary, definitely. Yeah. And with the bowel diary, suggest you use the Bristol stool chart. You can download this from the internet really easy, and basically choose your poo. Type 4, the smooth thin sausage, is basically the pinnacle of all poos and the one that we're aiming for. If your child has, you know, certainly type 1, type 2 all the time, they're certainly indicating that they have got constipation, or if they're always really sloppy, there may be some underlying constipation as well. But this will give us really good information whether we need to treat them or not. The other thing is the diameter of your child's poo as well. So sometimes, oh no, if they go every day, it's no big problem, but they may be doing a really big fat poo. We expect the bowel motion to just be a smooth thin sausage. So constipation. Now, if we treat constipation, it can resolve bedwetting in 63% of cases. And if your child day wets at all and they're chronically constipated, if we treat the constipation, it can resolve daytime wetting in 89% of cases. And I guess this is one of the reasons why health professionals, that we get so hung up on bowels when we're treating the bedwetting or whether we're treating day wetting is because there's a really close link between bladder and bowel. And research suggests that up to 30% of children do suffer constipation. So it is really common. So how do we treat it? Laxatives to prevent withholding behaviour and to treat the constipation is really important. And it's not uncommon for some children to be on laxatives for over 12 months. If your child is chronically constipated, there is really no quick fix. But we can't just give laxatives to children without having a really good sitting regime. So we certainly encourage children to sit on the toilet 20 to 30 minutes after a meal. What this does is take advantage of the gastrocolic reflex. So normally the contents of the bowel just move forward and back. But 20 to 30 minutes after a meal, the contents of the bowel can actually propel forward 30 to 40 centimetres. So it's a really good time to have a little sit on the toilet. And this gastrocolic reflex is often strongest in the morning. So if you can get your child to do a good poo before going to school, it means that they're less likely to going to have constipation, because a lot of children will hold on at school and try to avoid school toilets. Another good time for them to have a sit on the toilet is when they get home from school and after dinner if they haven't been at all. And we only expect children to sit on the toilet for 3 to 5 minutes. I don't expect them to be sitting there for a prolonged time. But a good sitting regime is really important, basically for all of us. It doesn't matter how old you are. And I will talk about how to sit on the toilet shortly. So a really good sitting position, which I'll show you in a minute. Healthy lifestyle. Now, this is just good for all of us. Exercise, adequate fluid intake, and a healthy diet. But we also know, and I'm sure Caroline's had children, there are some children who have the best diets in the world and they're still chronically constipated. And there's those who eat, let's say, a questionable diet or a really limited diet, and they're as regular as clockwork. Basically, we are all different, and it's not all down to what goes in. We know pears, kiwi fruit, and prune juice are really good fruits to actually encourage the bowels. And particularly if your child has any special needs, identify any barriers as to why they mightn't want to be using the toilet, why they mightn't want to be sitting on the toilet. Have they had a bad experience in the past? Of course, school toilets, often children really avoid using those. So laxatives. Laxatives are often, given long-term in children. And I guess the two most common ones are the Macrogol 3350, which you may know as Movicol or Osmolax. And then there's a lubricant, Parachoc. Now, if you are giving Parachoc at all for your child's bowels, it's important to give that at least 2 hours prior to going to bed. Now, it's really up to the health professional you're working with as to what type of laxatives to use, and we can't give you any advice regarding that. One thing we do is really try to avoid any rectal medications. We try to work from the top down with children and avoid their bottoms as much as possible. So how do you sit on the toilet? So it's really important to have a straight back, then lean forward, bending from the hips, and put your hands or elbows on the knees. And you want their feet to be well supported, and a little footstool under their feet really helps, because we want their knees to be slightly higher than their hips, because at the end of our bowel, we've got a bit of a corner, what we call the anorectal junction. And by sitting in this position, what it does is help to straighten that out. So it makes it much easier for the poo to come out. And if they can just blow gently, what they're trying to do is blow out just gently the lower part of their tummy, just below their belly button. And of course, not to rush. Now, so basically now your child's got a good fluid intake, they're not constipated, they're emptying their bladder just before going to bed at night, and they're about 7 years of age. So one thing we do know, children respond well to alarms at 7 years of age, and we know this is a good time to be treating bedwetting because, as we said earlier, we don't know which children will so-called grow out of it and who will go into adulthood as bedwetters. One thing we do know, we are much better to be treating at 7 years of age because we don't want it to be affecting their confidence. And it does upset me sometimes on the helpline. I'll get a phone call from a mum who said, oh, I saw the doctor, when my child was 6 or 7 years of age, and they said, don't worry about it, just give them time, they'll grow out of it. You don't need to worry about treating them. All of a sudden, their child's 12 years of age and still wetting the bed, and they call us. Whereas really, we would like to have this child dry around the 7 years of age. I don't know whether you've had much experience with that as well, Caroline, where, parents just have been waiting for their child to so-called grow out of it, and it just hasn't happened.
Oh, definitely. I also work at the Children's Hospital at Westmead and in the bladder clinic there, and we are there as well as here. We see lots of children that present even in their teenage years. And well, I've had, we've looked after children, well, young adults really, that are in year 12 at school, about to leave school, and it's just heartbreaking. So yeah, the younger you can implement treatment for bedwetting, the better, really, because it really does start to impact on the children's lifestyle and their self-esteem, and it limits their ability to be able to go on sleepovers and school camps and all those sorts of things. So really, we do advise earlier the better.
Definitely. So with alarms, basically there's two different types of alarms. This is a personal alarm. Now, basically you can get personal alarms off the internet anywhere between about $100 to $200 for something that's reputable. I don't know if you agree with that, Caroline, but I think you probably need to spend around that to get something of a reasonable quality. With a bedwetting alarm, if it's a battery operated one, make sure you've got a good supply of batteries because we want that alarm to be loud. It's also important to let everyone else in the household know that this alarm is going to be quite loud, and unfortunately often it wakes everyone else up in the household, maybe prior to the child who is actually being affected by bedwetting. The other really important with an alarm is make sure you set the alarm off prior to going to sleep. Just pop a drop of water on it. What that does is try to tune your child's brain into the sound of the alarm. If you find that they don't respond to the alarm, you may need to sleep in their room with them. So you can wake them as soon as the alarm goes off and say, quick, quick, your alarm's going off, because your child has to be responsible for turning it on and off. And we know alarms are the most effective way of treating children with bedwetting. If your child's really sweaty, you need to try to keep them on the cooler side. Don't load them up with blankets, because sweat can certainly give you false positives. And then there's also a bell and pad system. This system, you can't purchase them. They're worth a couple of $1,000s, but a lot of bedwetting clinics actually use these. When the wee crosses 2 wires, the alarm will go off. Now, I'd like to share with you, with the next one, my screen, and hopefully this will work. This is a clip from the children's. You can't see that yet, can you, Caroline? Okay, I'm just going to share the new screen.
Yes, I can see that.
Okay, I'm just putting it on. Can you see that now?
Yes.
Great. Okay. Now, what I'm going to do is I'll just
That's working,
this.
Janine.
Hi, I'm
Great.
Dr. Lexi Freidenberg.
I'll just bring it forward a little bit. Now, this is a clip from the Children's on how to use a personal
unit.
alarm.
A sensor that detects wetness, and the sensor cord that connects the sensor to the alarm unit. To use the alarm, first connect the sensor cord to the alarm unit. This can stay connected for the whole time you are using the alarm. Then attach the alarm unit to your pyjama top, near your shoulder. Here, the alarm noise will be closer to your ear to wake you up. It's also less likely to detach if you move around in your sleep. If you've chosen an alarm that vibrates, it's important to keep it close to your body. Pass the sensor cord down the inside of your pyjama top. If you're using a standard sensor, attach it to the outside of your underpants, where the wetting will happen. Then put a second pair of undies over the top. This holds the sensor in place. If you're using an easy clip sensor, attach it to your undies where the wetting will happen, like this. Remember to lock the clip onto the fabric by pressing down the lever. When the sensor gets wet, the alarm will sound and it may vibrate. Some alarms come with a range of different sounds, vibrations and lights. To stop the alarm sound, you need to remove the sensor from your wet undies by lifting the lever. And press the reset button on the alarm unit. Simply pressing the button without removing the sensor won't stop the sound. You should then get up and go to the toilet to empty your bladder. It's important that you go to the toilet because this helps to train your brain to respond to a full bladder, even during sleep. When setting up for the night, it's helpful to place spare undies and sheets next to your bed. You can then get changed into dry undies and pyjama top, and perhaps with the help of your parents, change your sheets. You can then reattach the alarm and sensor and go back to bed. If the alarm goes off a second time, repeat the same process. After 2 wake-ups in one night, we suggest you leave the alarm off for the rest of the night. We recommend you use the alarm every night for a period of 8 weeks. The first 2 weeks can be the hardest, with the alarm sounding most nights. For some children, waking up can be hard. Most children tend to sleep soundly. To make it easier, your parent or carer might be able to sleep near your room to help wake you up when the alarm sounds. A parent or carer could try calling out your name, switching on the light, or gently tapping your shoulder. But it's important that you're the one who turns off the alarm, not your parent or carer. Again, this helps to train the brain. Before starting the alarm program, you must want to stay dry overnight, and both you and your parent or carer need to be willing to persist with the program. After 2 or 3 weeks, you might notice that you are wetting less often and a smaller amount. We recommend you keep a diary. This will show your progress over time and can be a positive reinforcement. Persistence will pay off. Once you are waking and going to the toilet by yourself, your parent or carer may not need to help you anymore, apart from offering reassurance and encouragement. By week 4...
Okay, I think I might leave it there. I'll just close that. Now, okay, you back?
Yes.
Sorry, can you see my screen now?
I can.
Oh, you can. I can't. Okay, let me just press this and hopefully we're back. Okay, now for some reason my slides have gone onto the other screen, so just excuse me. I just need to I'll be looking at the other screen. My camera's on this one, but my screen has moved. Let me just see if I can change that. I might just leave it. Okay. So bedwetting, so you've tried an alarm program. If that's not working for you, there is also medication. But I'd certainly strongly recommend that you have a look at the different videos, because it will give you some guidance, particularly if you're doing it on your own without a health professional guiding you. So there is medication that's also available, and there's two different types of medication that's often used. One would be the desmopressin, the Minorin. Now that comes in wafer or tablet form, and its job is to decrease the production of urine overnight. Now, it's certainly not something I would be suggesting for the young child, though it could be used for school camps or for sleepovers and those times. And it certainly is contraindicated for those children who can't control their drinking, because we do have to limit their drinking once they've taken it and 8 hours after taking the medication. Then the next medication is the oxybutynin, the ditropan or oxytrol patches. That's often used for children who have an overactive bladder, who are actually urinating a lot of different times through the day or night. Now, of course, these medications are only available by script and has to be prescribed. Bedding protection is really important as well. As you saw on the clip, they did have bed pads that go on the bed. You can get waterproof doona covers and also waterproof sheets. So that's something else that can sometimes make life a little bit easier for both you and your child. Just some tips for school camps, and I'm sure, Caroline, you've got some extra ones as well, but it is really important to make sure that the teachers are aware and that you've got a plan in place as to how to dispose if they are wearing a pull-up or something. Sometimes it might be being allowed to go back into the cabin to dispose of it when no one else is present. You can actually purchase waterproof sleeping bag liners, so that's something good for school camps. Some parents might send 2 pairs of PJs the same, so if one pair gets wet, your child can change into another pair so no one notices. And it may be a time when you consider medication as well. But I guess one thing is that your child's certainly not going to be the only one on school camp who could potentially have this issue. So let the teachers know so they can support them. I don't know if you've got any other suggestions for school camps at all, Caroline?
No, that's very good. I mean, there's certainly lots of different products available. I mean, that's where it's great to when you're seeking management for bedwetting or daytime wetting, or is to speak to your continence advisor or seek a continence advisor, have a complete assessment, so we know that we're not dealing with an underlying bladder problem. So if that was the case, we would deal with that first, the daytime, and then we would look at dealing with the nighttime. And there are many products available that would be suitable, especially for camps and things. So speaking to your continence advisor is really, really important before starting treatment, like going out and purchasing an alarm, which may or may not be durable, and also to have the knowledge of how to use it properly to get the best effect.
And I think the other thing is too that sometimes on the National Continence Helpline, we might get a call from a parent that all of a sudden it's only 2 weeks until school camp, and then all of a sudden they hit the panic button. Whereas, think about it 6 months early. Often that there will be a school camp coming up in a certain year level, so we can actually hopefully treat your child and have them dry prior to that would be ideal.
Oh, yeah.
Continence care plan. This is just a really simple care plan that we have on our website, but every education department also has continence care plans. So if your child is experiencing any day or nighttime issues if you're going on school camp, make sure there is a plan in place to support them. And so that's really coming towards the end of the presentation. Are there any questions at all, Caroline, or
no,
anything that I guess one thing is that I think that we've said is if your child's 7 years or older, make sure that we do, that we are proactive, that it is a really good time to be treating the bedwetting. Call us on the National Continence Helpline. We're open 8 a.m. to 8 p.m. Monday to Friday, Eastern Standard Time. And yeah, we can certainly help guide you as to who's in your area. And yeah, is there anything else that you think we've missed, Caroline, or any other tips that?
I might just comment a bit on the alarm training, if that's okay.
Yes, please.
Yeah, so certainly when you're doing alarm training, it's important to make sure that the child is ready for the alarm training. So they're eager to become dry. It's really hard to expect them to comply with being woken up in the middle of the night if they're not ready for it. So that certainly would be a big point.
Yes, so it's not always just the parents. You've got to make sure your child's really on side and wants to be dry, definitely.
Exactly.
Really good point.
The thing is choosing the right alarm for the child. As I say, there's many alarms available, and certainly when I assess a child, part of the assessment is, and we're doing alarm training, I would go through the different types of alarms and pick the best alarm for the child, because you want them to be comfortable with the alarm training process, even though it is quite rigorous, but they need to be comfortable with using the alarm. I usually mention to the families, that alarm training is very, very strenuous, and once the child is willing to do the alarm, it needs to be consistent. So alarm training every night. Now that's where desmopressin or Minorin is quite handy in the alarm training process, so the child can have a night off and not regress backwards. So using Minorin on the nights that they want to have a sleepover, or it's not practical to do alarm training, is quite a good thing.
I think the other thing that just with the Minorin too is that if your child is on the Minorin, they'll usually go on it they may be on it for 3 months and then go off for a week, on for 3 months, off for a week, to actually see whether their own antidiuretic hormone has actually started to kick in. For those children having a school camp or sleepover, it's important to try the Minorin prior to doing that, because it doesn't work for everyone. And the other really important thing, I think, for school camps, I don't know whether it still happens, but probably back in your day as well, with you same sort of as me, Caroline, that they always offered hot chocolate, hot Milo at night, sort of at 8 o'clock or something. Yeah. It would certainly be something that would discourage your child to be having it if they've history of wetting the bed, and certainly if they're going to be using Minorin, you don't want them having that fluid at night.
And that's where the parents, having a chat with the teachers at the camp, and just letting them know that what the situation is, and if they maybe can offer something else. But I mean, we really don't want your child drinking close to going to bed, but maybe a little earlier, and something other than hot chocolate, which we know is a diuretic and a bladder irritant because it has caffeine in it. So
and certainly if they're using Minorin, well then they we don't want them having anything
yes, definitely
an hour before going to bed, definitely.
The other thing I would say with the alarm training is I would recommend, rather than putting the alarm, especially with the body worn alarms, in 2 pairs of underpants, using a panty liner and putting that in the underpants, and then it's in the lining of the panty liner, and which is attached to the underpants, and it's less likely to be dislodged.
Yeah, and you can just often lift up that first film of a panty liner and slide the little sensor in.
Yeah, and there are a product available that has the alarm in a pajama bottoms or underpants, which are really wonderful. Which, you know, the continence advisor that you see would be able to tell you about, which is a wireless alarm, and it's a really great alarm system. So yeah, there are different types out there.
I think that's probably all. So I'd just like to thank everyone for joining us today. If you have any questions, don't hesitate to reach out to Carolyn in New South Wales, or call the National Continence Helpline, where we're all continence nurses on the line who can help give you advice and point you in the right direction. So thank you for joining us.
And a big thank you from the Continence Foundation in New South Wales for Janine joining us from the National Helpline in Melbourne, and for Caroline for being available and online for this session today. I'm just going to share a little poll, which is a little way for us to understand the value of this session today, if you don't mind just filling that in. And I have popped the details for our paediatric clinic in New South Wales on the screen. We do that in our clinic rooms, but we do have a telehealth service available as well. And the National Continence Helpline is available to everyone wherever you are in Australia. So thanks so much for joining us. I wish you all the best on your bedwetting journeys. Thanks, everyone.
Thank you.
Thank you.
Has that poll come through for everyone?
Yes, it has.
Yes.
Beautiful.
So
Hello, Tricia. Hello. I think you might be muted.
oh, it's Tricia. Yeah.
Hi.
Hello.
How you going? That was
Good, thank
really
you.
good.
Oh, hi, Tricia.
Hi.
I didn't know who was around, but hopefully, yeah.
No, that was really good. It's good for me to know it from the other side sort of thing, just so I know that I'm keeping up to date with what I'm talking to people about, even though I do suggest them to speak to you guys, not me.
Yeah.
But, yeah. You well?
Yeah, I'm good. I'm better now.
Are you?
Yeah, because I'm over this, over the presentation.
You did very well.
It was really well. You did really well. I didn't even notice you were nervous. It was really well done. Yeah, that's good.
Well, I think it's also good because I think it's really boring to listen to one person's voice for even half an hour is hard, you know, like, whereas having, I think, Caroline, you joining in.
I think you both worked really well together. You both said different things along the way. So that was good. And it's good to hear a couple of people's opinions.
Yeah, thank you.
Because we only just met each other 5 minutes ago, so that's good.
We've spoken over the phone, haven't we?
Oh, right.
And I do recognize, I'm sure I've seen you at a conference or something, but at least next conference we'll be able to introduce ourselves in person.
Definitely.
How funny
Be
is
like
that?
old friends by then.
That's the beauty of Zoom, isn't it? Like you get to see people face to face and still feel like you're really interacting.
Yeah.
Mm.
Yeah. But I don't know why after the I did the video, my screen didn't go on my laptop. It went to my big screen, and I'm thinking, oh, and I haven't got any notes with me. So I think I've got to look at this because I don't know what's come up. Yes.
Oh, wow.
No, all's good.
All right. Well,
thank
nice
you.
to see your faces again.
Yes, thank you, Tricia.
Lovely to meet you, Tricia.
I'll speak to you again soon.
No worries.
Thank you.
All right.
Bye-bye.
Thank you.
Okay.
Bye.
Bye-bye.
All right. Bye, Carol.